Well, hello and welcome everyone to today's event. And a big welcome to all of you joining us from around the world. Antia told me before we got started, we have about 120 people registered, which I'm very excited about. We all are. My name is Krista Donaldson, and I am the Director of Innovation to Impact at Stanford's Masalem Center for Biodesign. Each month, we host a different talk as part of our Health Equity and Innovation discussion series, where we explore different perspectives on using innovation to narrow inequities. I want to thank our partners, the Center for Innovation and Global Health at Stanford, the Bay Area Global Health Alliance, and Stanford Global Health Graduate Network for joining us and bringing these events to life. And a warm welcome to all of our partners, wherever they are joining us today. Since today is a fully online event, if you just joined, we'd love for you to put in the Q&A where you are joining us from today, because there is no chat because of our webinar type. And yeah, it's just to see where everyone's from. Our speaker today, I actually met, Maryam, you're gonna laugh, Dr. Maryam Mustafa. We met actually on a bus in Senegal. The bus took a circuitous route coming home from the conference. I don't know, I think it was the end of the day, but long story short, there are blessings when your bus gets lost coming back from a conference, because that's how I met Dr. Mustafa. And she is doing some really incredible work. So let me tell you a little bit about her and her work. She is an associate professor of computer science, the director of the Gender and Technology Cluster, and the director of the Saida Waheed Gender Center at the Lahore University of Management Science in Pakistan. Her research examines technology, design, access, and adoption in diverse and developing contexts and across intersections of gender, class, and religion. Much of her work focuses on leveraging AI technologies to improve women's intimate and reproductive health in Pakistan. Her recent work is funded by Google and the Gates Foundation, which has led to a startup in Pakistan, Awaz-e-Sehat, and you will correct me, Dr. Mustafa, if I'm not pronouncing it correctly. It means voice of health, and it's Pakistan's first conversational AI assistant for maternal health workers. It autonomously generates electronic health records from speech in Urdu and provides personalized, timely diagnostic information tailored to patients. She will be joining us today to talk about, hopefully, all of her work, but in particular, data biases in the age of AI and their impact, her learnings and insights, and what equitable AI technologies might look like, and how to innovate in complex, nuanced contexts to serve the most vulnerable and marginalized communities. So, Dr. Mustafa, thank you so much for joining us today.
Thank you, Krista. That was such a lovely introduction. Thank you, everybody, for joining. It's just such a pleasure to be able to speak to you today about my work in leveraging large language models to address some of the critical needs in maternal health in low-resource contexts, but more broadly about how contextual bias has historically shaped biomedical and health innovation, and how in the age of AI, those effects are often magnified and amplified. And we'll talk a little bit about how they play out in the real world. I just want to quickly check if you can see my slides, Krista.
We can, thank you, yes.
Oh, fantastic. So before I dig into my own work, what I would like to do is take a moment to contextualize the problem with a very brief look at the historical roots of bias in health innovation. Because what you'll find and what you'll see as I talk about my own work is how those historical roots play out in the age of AI as well. So the trouble actually begins before a model ever trains, during measurement, when our framing decides who is counted, who is left out, and our instruments set errors that models later inherit and amplify. So for example, recent studies have shown pulse oximeters overestimate arterial oxygen saturation among Asian, Black, and Hispanic patients. And so I'm going to let you sit with that for a second and think about and imagine the impact that this has had on treatment plans during COVID-19, when your oxygen levels were actually shown to be higher than they were. And only recently, I believe in 2025, has the FDA moved to tighten guidance so that validation and labeling are more inclusive. We've also historically seen an underrepresentation in training data and trials, and this might not be news to clinicians who are joining us. For decades, clinical trials have largely omitted women. Until 1993, US trials were not required to include them. So dosages, side effects, and normal ranges were built around male physiology. And as you can imagine, the consequences have been predictable and they've been preventable. So for example, symptoms of heart disease in women can present differently for men. We know this now, but data collection has historically and continues to emphasize the male pattern. What this means in practice is that women aren't just understudied, they're unseen. And a recent analysis found that women under 55 are 7 times more likely than men to be misdiagnosed and sent home during a heart attack. And the reason I'm emphasizing this and I bring this up is this is something you'll see again when I start talking about clinical decision support from AI systems. So we also find that when evidence is unrepresentative, care becomes uneven, and by default, that any models that you train on this evidence will inherit the same blind spots. We also see that erasure that grows in places, it's amplified where measurement is hardest. So for example, in the US, Black women are 3 to 4 times more likely than white women to die from childbirth or childbirth-related causes. Global health data systems often ignore or undercount maternal mortality, particularly in low-income countries like Pakistan, because it's so hard to measure maternal health and it's so hard to measure maternal mortality. Estimates show that in the global data, 60% of maternal deaths are never officially recorded. So putting all of this together, all of these forces that play out, biased measurements, underrepresentation, label skew, domain shift, what you find is a pipeline of inequity. And at each step, choices are made that determine who is visible, who is credible, and deserving of intervention. And AI does not make these choices, but it accelerates their consequences. So when we feed unequal data into systems that are optimized to generalize quickly and at scale, what we're doing is that we're amplifying what the inputs are. We're amplifying what we started with. And if the inputs exclude, the outputs will do it too, only much faster with AI systems. So we really need to ask ourselves, whose data is collected? Who is counted when you're talking about large language models? Now, to train large language models, you need large amounts of data. And the best way to get that data is through the internet. Most large AI data sets are scraped from the internet, Wikipedia, Reddit, Twitter, YouTube. What this effectively means is that they heavily overrepresent people who are young, urban, educated, English speaking, and this is important. We'll come to language. We'll talk about language quite a bit today. And they're connected online. The bulk of this data is coming from the global north. So for example, Wikimedia's own survey shows 80% of Wikipedia contributors are men. They are concentrated in North America and Europe. And you can imagine that this skews heavily what AI knows about the world. So the world that the AI knows is formed by the data that's fed into it, and that is predominantly global north, white, male. Unsurprisingly, the representation of women online is not only smaller, but often distorted and stereotyped. This is also true for people of color. So for example, when women of color do appear, they are disproportionately labeled with terms tied to stereotypes or derogatory categories. What's also really important to highlight is that non-English speakers, large language models overwhelmingly train on English text. And so other languages are underrepresented or absent. And we'll see the significant impact this has when you try and take large language models and you try and deploy them in the real world in contexts that are not English speaking. We find that inequity keeps showing up because the entire health innovation pipeline, even before AI came into the picture, what we measure, who we sample, how we label, how we train and deploy, still encodes historical exclusions and skewed incentives. And so what I'd like to talk about predominantly today is my own work and the learnings that we've had from that real world deployment in Pakistan. But before I can do that, before we can get into what we've built and how we iterated over it, what we've learned, it's important to understand the healthcare system in Pakistan and the context in Pakistan for any of our design choices to make sense to you. The healthcare system in Pakistan consists of 3 arms predominantly. There's the public health sector that is run by the government. It is free and it primarily caters to low-income families. The public healthcare setup also has tiers within it. So rural and peri-urban areas will have what are called basic health units, which refer to the secondary health centers, which then will refer to a tertiary hospital that has more resources. The second arm is not-for-profit and charity hospitals that also predominantly cater to low-income families. And then the third arm that you have is private healthcare, where sort of rich elite families will visit because they have the finances and the money to go to these places, and they're better staffed, better resources, they have better tech, better trained clinicians. None of these arms talk to each other. Even within a particular tier, clinics and hospitals will not talk to each other. So you're responsible for taking sort of physical data files to every clinic you go to. And if you're not able to explain what has happened to you in terms of your healthcare, your clinician has no clue what medicines have been prescribed, what your earlier illnesses have looked like. There is no centralized health records that any clinic or any hospital can access. I've spent a lot of time in Pakistan doing ethnographic and qualitative work to actually understand and explore gaps in maternal health that technology might be able to address. And during my ethnographic work, one of the stories that has fundamentally shaped the ways in which we've built our tech and sort of the place where we started was the story of Samina. Samina lived in a village near Lahore, and she was pregnant with her first child. And the only healthcare, she's from a low-income family, and the only healthcare worker she had access to was a midwife, an untrained midwife, what we call in Pakistan a dai. And this dai assured her of a very healthy pregnancy. But starting in her 4th to 5th month, Samina started to feel very swollen, bloated. She started to have dizzying spells. Her vision got blurred. And every time she would go to this midwife, the midwife would tell her, this is all normal. This is just your first pregnancy. That's why you're scared. But this is all normal. She made it in a very progressively sort of worsening condition to her 7th month when she started to have seizures. And at that point, she was rushed to a primary care facility. Keep in mind that the public health sector has tiers. So she was taken to the primary health facility, which sent her to the secondary health facility, and that sent her to the tertiary health facility. And this was in December. So it was very cold, and the only transport they had was a tractor, like this truck, and she was put on the back of this open air truck. When Samina arrived at the hospital, she was in a coma. And she didn't make it, and her mother didn't. She didn't make it, and her baby didn't make it. And turns out what Samina was experiencing were symptoms of eclampsia and hypertension, which went undiagnosed because the midwife, the dai, wasn't trained to look for these signs. And had she been diagnosed earlier in her pregnancy, she and her baby would both have been fine. And so one of her earlier questions, this is 7, 8 years ago, was how do we save women like Samina? Because clearly this is preventable. The challenge that is experienced is the delay in understanding that you need to go to a hospital, and then the delay in getting to the right hospital. So would it be, and our first thought was, is it possible for us to build a predictive model that if Samina were to, or women like Samina were to send us a message saying, I'm experiencing these symptoms, can we get back to them based on a predictive model to say there's an 80-90% chance that this might be preeclampsia, and here's the healthcare facility you should go to within the next few hours? So if you can cut down on those delays, can you help save women like Samina? And so we went to one of the largest public hospitals, maternity hospitals. So they deal only with pregnant women in the region. And we asked them for their data to build this predictive model. And the reason we didn't go to a private hospital for this data is because we wanted this to be the data to represent the vast majority of women in Pakistan. If you're a woman and you're going to a private hospital, then you don't have the same kind of lived experiences. You don't have the same nutrition. You're not taking the same supplements. You're getting regular health checks. So your health data is going to look very, very different from somebody who's in a village and who perhaps gets to see a formal doctor or clinician once a year. And we wanted representative data of a large majority of women. So we went to a public hospital, and they were super psyched. They said, this is great. This actually might work, especially if we can help untrained dais and midwives refer in time, have them sent to a hospital and the right facility in time. You could actually cut down on the number of preventative deaths. And they said, we will happily give you our data. And they took us to a room that was floor to ceiling physical notebooks of data. Just registers of pregnancy data that I could not digitize in my lifetime. And at that point, we had to take a step back and say, well, so the bigger problem is that there is no digital data to do any kind of analytics on, to understand what the pregnancy journeys for women in this country look like, to build any kind of models on. And so that's the problem that we figured we would try and solve. Now, to do that, you really need to understand the development or the tech landscape in this country. Not only is Pakistan one of the countries that contributes, I believe, half of the maternal deaths in the world, one of 4 countries. We also have a very skewed physician to patient ratio. We have about 11 physicians per 10,000 people and only about 5 trained nurses or midwives per 10,000 people. We are also on like the last on the Global Gender Gap Index that the World Economic Forum puts out every year. We were second last year, but then they dropped Afghanistan, and now we're last. Internet penetration is about 45%, and women are 48% less likely to own mobile phones. So what that effectively means for me as a technologist and somebody building tech in this context is women will have access to shared phones. So any mental model that you have of privacy on a personal phone that you own, that you can lock, that is, WhatsApp or Instagram or Facebook, that is yours to use, that nobody else has access to, gets thrown out the window. You also then have to account for intermittent access. So if a woman is using a shared phone, there's one phone in the household. Very often it's her husband's phone, and maybe she gets access to it for half an hour or an hour when he gets home from work. How do you design for that? How do you build for that? And in all of that, how do you ensure representation? In addition to all of this, Pakistan is primarily an oral culture, and we have over 70 languages that are spoken. Some of them are oral only. What I mean by that is that there is no alphabet. There is no written concept or form of these languages. They are passed down generation to generation orally. And so when you're building for the masses, when you're building for an untrained midwife who's sitting in a village in Pakistan, you're not counting on her knowing English. You're not counting on her being able to read or write or be digitally literate. And so those are the sort of considerations that we had when we built Awaz-e-Sehat. Now, the Awaz-e-Sehat system is designed to support the creation of digital medical records by streamlining patient data collection using a combination of speech-based input and natural language processing through LLMs. The idea is really, really simple. Can we use speech and local languages over simple smartphones to generate structured medical records? Patient histories are recorded across 6 categories, and these include previous pregnancies, current symptoms. We're working, one of our co-founders is actually an obstetrician, clinical gynecologist, and we're working with gynecologists in public hospitals to create a medical record that a set of data points that would have the strongest sort of predictive impact on outcomes. And so what we're finding, particularly for our context, is that in addition to previous medical history, a woman's agency within her own household, how educated she is, how much money there is in the household, all of those play a role in birth outcomes. And so we're collecting that as well. The audio recordings so this system that we built, this is the first version that we built, and this was completely focused and designed for maternal health workers. And we were going off of our understanding of how electronic health records are created globally through maternal health workers or clinicians. So hospital staff, clinic staff. And that's what we were going off of. And so this was speech-based, healthcare workers, audio recordings that were then transcribed using OpenAI's Whisper model. Which was fine-tuned with recordings from the hospital to address challenges like code switching between languages. What that means is that we're working with regional languages. And the challenge is that the only regional language for which there is enough data to be able to do any kind of speech to text or text to speech is Urdu. And when you're working with clinicians, they will often switch between Urdu and English. What they'll also do is that they will use colloquial terms. So they will say, and this is with clinicians, the problem it takes on a very different shape once we deploy it. But clinicians will also use colloquial terms. For example, they will often, when they say the patient has diabetes, they will not use the term diabetes. They'll say the patient has sugar. And a large language model transcribes that and understands that as sugar and not diabetes. And so for this version of the system, we had to build a customized dictionary of the most frequently occurring colloquial terms that clinicians were using to be able to fine-tune the large language model as well. The generation of the medical record, once the speech was recorded and it was converted to text, the structured medical record was powered by GPT, which processed the transcriptions and created these structural records. Now, we also had the system ask follow-up questions guided by medical guidelines to ensure A, there were no errors, and B, that the medical records were complete. So if a clinician forgot to ask something that would be very relevant to predicting any kind of outcome or any kind of risk factor, the system would go back and ping the clinician. Can you tell me this about the patient? What we then also did was that to help midwives and sort of low-skilled health workers, we had the system create critical health risks, highlight them, or red flags, as we're calling them, in the EHRs. And these were prioritizing key maternal health indicators. So, the patient has a high likelihood of perhaps displaying symptoms for diabetes or anemia. And this was based on the patient's history and all the data that we had fed into the system. Now, this system was deployed for about 6 to 7 months at one of the largest not-for-profit hospitals in Pakistan and generated about 600 to 700 records from patients. And this was deployed with nurse practitioners and clinicians working in the outpatient department at Shalimar. Now, the evaluation and our fleet deployment, it included both the quantitative and qualitative methods to evaluate the effectiveness of key components. So the three main things that are coming that are output from our system are the transcriptions that are generated from the speech that is recorded, the output from the large language model, the electronic health record from the large language model, and then the red flags that the LLM is generating based on the health records and based on clinical guidelines, obstetric clinical guidelines. And so for each of the patient, we also generated, for each of these patients, we generated a manual ground truth. So we listened to the transcriptions, we created a manual electronic health record, and then we compared that to the system-generated health record. And what we find is the accuracy was around 97%. And there were less than 2% errors where we required the ground truth for correction within the system-generated EMRs. We also put together a panel of senior obstetricians to help develop a targeted evaluation metric for the large language model generated risks or red flags to see how well they aligned with A, established medical guidelines, and B, the other thing we wanted to see is how applicable or relevant they were to the patient's data. And with that, we found accuracies to be on both dimensions to be 97% and 94% respectively. We also retrospectively went back and looked at our system at the red flags that it was raising and what the clinician diagnostic plan had been. And we found that our system could support approximately 4 to 6 times improvement in the identification of actionable red flags for patients. And we looked at anemia, hypertension risk factors, and diabetes. Now, at the end of this was about 7-8 months of work. And at the end of that almost year, we were really happy with the results we were getting. And we thought we had finally figured out how to build for improving healthcare outcomes in this context. It turns out we had not accounted for clinician time or will, because outside of the pilot, once we tried to deploy it, we found, clinicians have about 3 to 5 minutes per patient. They don't have the time or the will to, regardless of how great your system is, how easy it is, compared to, it's on a smartphone, it doesn't require electricity because very often there is no electricity in the locations where we work. It does not require you to have an expensive, bulky system. It's light, it runs on the cheapest smartphones. None of that matters because clinicians just don't have the time. We saw we have about 10 to 11 clinicians per 10,000 people. Those clinicians are overworked, they're underpaid, they have no motivation, no incentive, and no time to take detailed medical histories. And so we went back to the drawing board to think about how do we reimagine this for our context. So we had been going off of the assumption that, health records need to be created by clinicians or healthcare workers, and that's what we had built for. But now we have another element in here, clinician time, and how do you optimize for that? Which had us thinking about who has the most incentive or the will to create these records, to make sure these records are detailed, to ensure healthy outcomes. And so what we did was we shifted our focus to patient-centered systems. And so we flipped our system completely. And we said, if we were to go do something, if we were to build placing patients first, what would that look like? And so our current system now is over WhatsApp because we find it is the most ubiquitously used application in the country. Women use it regularly to connect because it allows for speech modality. WhatsApp is one of the only messaging systems that actually allows you, it's multimodal, it allows you to share videos, images, but to communicate through speech. So you can leave voice notes. And that's why it is predominantly used in this country across socioeconomic classes. And so the patient-facing element of what we've built is now over WhatsApp. And what it allows you to do is there is an AI agent that takes on the role of a clinician. One of the things that we discovered in hanging out at hospitals for many years is that women spend an inordinate amount of time waiting in waiting rooms to see the clinician. So they might spend anywhere between half an hour to an hour to 3 hours, depending on how many women showed up that day, waiting for their turn to see the clinician. And we wanted to use that time. And so over any phone, over WhatsApp, you have an AI agent that takes on the role of a clinician and helps you record your own medical history. So it will ask you what your age is and how educated you are and how many children you've had and what are the ages of those children and were there cesarean births or were there vaginal births. It will ask you what your symptoms are and it will do this in Urdu. And based on your responses, it will ask follow-up questions. So it's a conversation through speech, through voice notes over WhatsApp. And at the end of that conversation, it will generate a structured electronic health record that will be available to the physician or the clinician on their app. So the clinicians have a separate dedicated application where all of this data shows up the minute a patient has finished reporting. What we've also built in is a conversational agent for women, because we found that when we were doing our qualitative analysis for our first trial, and we were speaking to women about their experiences, one of the things that kept coming up was women reaching out to my team to ask health-related questions. So they would ask questions like, I'm 7 months pregnant and the road that leads from my village to the main road is broken. And can I sit on the back of my husband's motorcycle and go down that road? Or they would ask questions like, oh, I feel like having raw rice and is that bad for my baby? And invariably, very often, we would have to bring in an obstetrician and do these information sessions for these women where they could get their answers questions. Because keep in mind, when they see a clinician, they have 3 to 5 minutes and that's it. There's no time for them to have their questions answered. And so what we've built into this is a conversational pregnancy support agent that they can ask questions through speech in their regional language. It gives them reminders of if there's a certain timeline or milestone that they need to hit or have hit, it'll tell them. It will tell them how their body is supposed to change, what is normal, what is not normal. And it will also warn them about unexpected symptoms they might experience in a particular month. And if they experience that's not nothing. It is sort of the national, I think, in the national character of countries like Pakistan, for patients to be very, very wary of going to physicians and clinicians just because it takes so much time. And so very often they will say, this will pass, or it will get better, or it will go away, or I'll just have more milk and it will and you want to be able to catch these symptoms early. The other thing that we find is that, one of the obstetricians in a public hospital said one of the things that contributes not just to the crowded conditions that we experience and the load that we experience, and that is really challenging for patients, is that if a clinician has asked a patient to go get a CBC, like a blood test, the patient will need to get that blood test and then they will come back and wait again. And keep in mind that when our female patients, when these pregnant women come in, they're often coming in from long distances, from far away, and they're not traveling on their own. So some male member of the family will need to take the day off, bring them in, spend a day at the hospital, and that day's labor for them is gone. And so, one of the things that came up early on was, is there a way to do this remote? So if they don't need to come in, if their blood tests are fine, if their radiology reports are fine, if they don't need to come in, can we let them know remotely? And so one of the things that they can now do over WhatsApp is to just send us a picture of their blood report. It gets attached to their EHR, their medical record that resides on the doctor's app, and the doctor can just send them a voice note saying, your blood tests are fine, you don't need to come in. The other problem that we're solving that's been a significant problem in Pakistan is the fact that the healthcare system is fragmented. So if you went to one clinic today and you went to a different hospital later and you went to a third hospital to give birth, none of them will have a concise medical history or data about your pregnancy. So they'll be operating and working blind to treat you. And so we want the women to own their own data, and we want them to be able to choose who to share it with and when to share it. And so what women can do is that they can request a QR code, and any clinician anywhere can scan that QR code and gain a timed access to their health records. The clinician just needs to enter their name, and their clinicians here get a registration number. So they need to enter their registration number to then gain access to, and they can add to it. They cannot change what's already there. So if you went to 4 different clinicians, they will all have added to one EHR, anything, any medicines they prescribe, any data they've given you. And every time a new clinician opens, they get a very quick summary of everything that's happened to you. So you are no longer required to manage pieces of paper or to remember what has happened to you, any medicines that were prescribed to you, and relay that in those 5 minutes to every clinician that you go to. Having patients generate their own medical histories over WhatsApp frees up those 5 minutes of clinician time for things that actually matter. So it frees it up for doing a physical examination and for making a diagnostic plan. So on their app, they can still add the details of the physical examination that they've done, any additional details that they have, and add their diagnostic plan. And they're also given access to the critical concerns that have been raised. Now, one of the features that we're testing, and we're not entirely sure about this, so if anybody has thoughts, I would love to hear. One of the things that we're testing out actually is because other studies have shown this as well, and this has been our experience with the clinical decision support that we provided to clinicians in our earlier trial. It's not very useful because they don't look at it. They don't look at it, they don't follow up on it. And so any impact that could have had will not happen with clinicians being on the receiving end of it. And so we're trying to understand how to package those critical concerns in language that makes sense to our patients, that doesn't overwhelm them and raise alarms, but that helps them advocate for their own health. So is there a way for us to package the messaging in language that makes sense to be able to say, there's a high risk for you to have anemia. The next time you go to your clinician, here are the things that you need to ask them, and perhaps request certain tests. And we'd like to see if that kind of placing women and themselves at the center of this, because they have the most to lose, and they have the greatest incentive for having sort of a good outcome to their pregnancy. And so is there a way for us, if there's a way for us to sort of provide this clinical decision support to women themselves and have them advocate for themselves from a place of knowing to the clinicians? All right. So not surprisingly, we've run into problems with the large language models we've used. And this is, I'm going to refer back to when we were talking about earlier, the historical biases in health innovation and how language plays a significant role in who's represented. When you train AI systems on predominantly men and you train them on data from the global north and data from the internet, it is not, and English speaking data, it is not going to be able to understand anything that, even though the Urdu language models are there, they're really, really bad at interpreting the ways in which women talk about their own sexual reproductive health. So diabetes and sugar was one example. But women in our context that is low literate and conservative, they're not going to speak about their own uterus, and they're not going to talk about their ovaries, and they're not using these formal clinical terms. They're not even using the formal Urdu terms for this. And so what they're using are euphemisms. There's a lot of gestures, and large language models are not equipped to deal with gestures. It would be really cool instead to have sort of the female anatomy and just have women point to where it hurts or where they're having a problem, because they don't have the terms for this. They use roundabout ways of getting their point across. So for example, when they're talking about having sexual intercourse, they're not saying, oh, can I have sex with my husband a month after I give birth? They're saying, when I meet my husband. And this is super confusing for a large language model. We've tried 5 of the most prevalent, predominant large language models, proprietary and open source, and they do really, really poorly when you talk about this. We've spoken to clinicians and they understand this because they work in the space. but this data is not represented anywhere. So what we're now having to do is build customized data sets and dictionaries to feed into our large language model so that it can understand what women are saying, because the context around those conversations also matters. What's also shocking but not surprising is that when the three best sort of performing models on our data were Gemma, Llama, and Cloud. And when you ask them to respond to women's queries in Latin Urdu, so that's Urdu that's written in the English alphabet, they come back with what you're seeing here in example 1, 2, and 3. They come back with Russian, and they come back with a language I don't understand, and they come back with nonsense. And so they're not even able to respond in text to women in Urdu, for which they do have a large amount of data. What we're also seeing is that when women ask certain questions, you get very problematic and stereotypical responses. So for example, one of the women asked, I'm 7 months pregnant, and I would like to exercise. What should I do? And it came back and told her to do housework. And that's really, that's a very stereotypical, but also very problematic response in a context like Pakistan, where women are already not seen in public life. And so when we saw that, we went and sort of contextualized the same model and said, oh, I'm an American white woman in the US, and I'm 8 months pregnant, and I'd like to exercise. What should I do? And the model came back and said, you should go for a walk. It's not telling American women to do housework. Very quickly, the other study I do want to highlight here that has very similar findings to ours is recently published in 2025 at the FACT conference, where researchers explored how specific data tweaks impacted clinical reasoning for vulnerable patient populations. So what their framework did was they changed clinical context in 3 meaningful ways that did not distort the underlying clinical factors that were relevant to patient diagnosis and was semantically preserving. And what they tweaked were gender markers, the tone of the query, so such as uncertain tones or colloquial language, and they changed syntactic tweaks, so adding white spaces and typos. Again, not surprisingly, I mean, they did this to understand how these tweaks impacted clinical decision-making and reasoning for 6 vulnerable populations: female patients, non-binary patients, or those who use gender-neutral pronouns, patients with health anxiety, patients with a more dramatic disposition, patients with less technological aptitude, and patients with limited English proficiency. And it was not surprising to me at all that female patients were significantly more likely to be told to manage at home instead of seeing a doctor. Adding simple typos to patient messages reduced care recommendations. Using uncertain language also led to less urgent treatment advice. And even something like formatting errors caused AI to suggest staying at home instead of seeking medical care. So basically, if you're relying on AI clinical decision support, your care plan will degrade significantly if you are a woman, do not speak English well, or are non-binary. So that brings me to sort of the point I started with and my final point as well. Health innovations will continue to struggle and fail with fairness and equity because bias is baked into the inputs, and then the tech is just amplifying what's already there. And so some of the ways that we've thought of handling or tackling this is designing for equity by construction. So not looking at this after the fact, but actually sitting down and thinking about who's this data excluding, who are we missing, who's being marginalized, who's being penalized, defining your priority populations, curating data to match reality. We've been guilty of this as well when we started with this assumption that healthcare systems or diagnostic systems need to be tailored to clinicians, but that kind of missed the context entirely. And so what is the lived reality of the populations that you're designing for? I think label governance is so important, and this is something that the FDA is now also catching up on. And monitoring and governing after deployment. So we have a panel of clinicians and obstetricians that look at the outputs continuously. They're the guardrails until we are absolutely certain that we have a system that is not marginalizing anybody, that is not penalizing anybody, that is not creating diagnostic plans that are less than what is required or what the optimal care is for a particular population. So those are my final thoughts on this, and I'd like to leave the rest of the time for questions if we have any.
Thank you, Dr. Mustafa. Please, if you haven't already, it looks like we may start to be getting some questions, but I'm going to hand it over to my colleague, Antia Krishner, to moderate our questions. Thanks, Antia, and thanks, Dr. Mustafa.
Yeah, thank you so much, Dr. Mustafa. There's an interesting question in the Q&A saying that localization is typical a historical challenge with all tech, not just AI, and not so much sexist or a global north issue, according to this attendee, but a scalability issue. Are you aware of any localization of big AI players or local players attempting to create localized models?
So part of that is true, but I also think that there is a sort of a blindness almost to really thinking about the data that we're using to train our models. There are examples of countries. I think the UAE has put out their own large language model. I think there are examples of countries that have that are now attempting more and more to create their own localized data sets. But I think there is no incentive for big tech companies to create localized data sets unless there is a push to do so. Because clearly, I don't think OpenAI cares what's happening to women in this country, in Pakistan, right? And so, we're planning to make all of the data sets that we curate and create publicly available, but that is not to say that a big tech company will take them and put them behind a paywall, and then who does that benefit, right? So I think it's a slightly complicated context.
Mm-hmm.
So I'm seeing Alice, I like that question. So the ways that in which I imagine label governance is really paying attention to how data is being labeled. And so, for example, we find that any content on Wikipedia or on the internet that has marginalized populations or say Black women, the labels are stereotypical, derogatory. So you want to be able to make sure that you're not using that blindly.
Yep, that makes sense. Thank you for the question, Alice. There's a participant interested in kind of hearing how someone can follow a similar career path or get involved in the kind of work that you do.
And Dr. Mustafa, can I add that we love hearing about founders' journeys? We have a lot of students on the call, and you are both an incredible academic and a innovation company founder. So we'd love to hear a little bit about your journey too. Antia, thanks for letting me jump in.
Yeah, of course.
Okay, so it's been a bizarre sort of and slightly wild journey because I'm a technologist, I'm a trained computer scientist. And I moved back. I spent most of my adult life, I would say, I did my undergrad from Pakistan and then I moved to the US. I was at Cornell for a while and then I went to Germany where I did my PhD, and that's where I was working. And then I got bored and I moved to Pakistan because Germany was very predictable. It was very black and white and everything just kind of worked. And there was less room for sort of getting your hands dirty or building things that really mattered. And so when I moved to Pakistan about 8, 9 years ago, I grew up in Lahore, the city I'm in now, but the city had changed a lot and I'd kind of forgotten what the layout of the city was. And I used to rely a lot on Google Maps. And it was a super frustrating experience because I was a woman in Pakistan, and Google Maps very often late at night would take me, and the women on this call will almost certainly have experienced this because every time I ask this in any room, regardless of country or geographic reason, all hands go up where we have women. It would take me down these weird back alleys. It would never take me, like, it would just optimize in a very male way where I would get from A to B in the shortest way possible. It would, and those often included really sort of eerily quiet neighborhoods, deserted roads. And for me, it was a scary experience. It was a super scary experience. And I would have to call somebody and have them stay on the call because I was terrified. I didn't know where I was. I was just hoping that Google Maps was right because sometimes it will lead you to a dead end. As a computer scientist, it was so frustrating because on my phone, it knows that I'm a woman. It's linked to my Gmail account. It knows my gender. It knows my location. It knows I'm in Pakistan. It knows it's after 10 p.m. It knows where all the shops are. It knows where the lighted areas are. It certainly knows where traffic is. So why is it not giving me the option? Why is it not saying, hey, Maryam, you're a woman in Pakistan. It's after 10 p.m. Here's the shortest way, but here's a way that's more crowded, that has more lights, that's not entirely sort of quiet. Maybe you want to take that because it's safer. It doesn't give you that option because clearly the people who built it are not women and they don't feel unsafe. And so that's kind of where the looking into how gender bias impacts the ways in which technology is built and sort of questioning who are we building for and who is it disproportionately impacting and marginalizing. That's where it started 8 years ago. And in Pakistan, so I work on health tech. I also build products for financial inclusion for women. Like in a country like Pakistan, where women have a hard time leaving the home, they're not going to a bank, and where there's low literacy, they're not filling out a gazillion forms to open a bank account. So how do you build products that work for them? Women, I find, are financially super savvy. They're a much better risk than men are. So when they make investments, they're very careful and they're very curated investments. There are just no digital financial products that work for them. So I work on understanding that, and underlying all of this is unpacking and understanding how privacy works in this context, because the ways in which women in this country have access to tech is very different. So it's not like I have a phone. Like I remember speaking to a woman once who actually did have her own phone, and I asked her, like, did she keep a lock on it? How did she manage her privacy? Because even when they have personal phones, they're often monitored, right? And she said, oh, like her two-factor authentication, she locked it. She had a password. She put that password on a piece of paper. She put that in a cupboard. She locked the cupboard, and she told me that's how she kept her password safe. So the ways in which sort of tech is built and the ways in which privacy is understood is just so different from the ways in which the global north understands it. And that's where I started. And it's taken me many years to understand what the healthcare system looks like in this country and the kinds of tools and products that might actually work in this context. Because, I would really encourage you guys to read, if you're interested in this space, there are two books I'd encourage you to read. I'd encourage you to read Invisible Women, if you've not already read that. And the other book I'd like you to read is by Kintaro Toyama, and I think it's called Geek Heresy. And one of the things that time and time again you see with tech, whether that's smartphones or that's laptops, is that anytime you deploy tech in a population, it will invariably always amplify existing inequities, right? It's not a band-aid. It's not like tech will suddenly get rid of everything that's already there. It will just make it worse. And this is my concern with AI in healthcare as well. And so a lot of the work has been to understand what that underlying layer is. How are the ways in which people are already doing things, and how do we amplify the ways in which they're already working to just help them do it better or more efficiently to build with communities? And then, a couple of years ago, because, this healthcare thing kept puzzling me, and I couldn't figure out how do I get the data to be able to build the predictive models, to be able to get women to get to a hospital in time, to be able to not die. That was the thing that we kept trying to figure out. And I think it was two and a half years ago that there was this Grand Challenges global call for applications in the healthcare space and in the AI and healthcare space. And we said, okay, can we build something that is speech-based, easily accessible on a smartphone, costs you nothing, that would allow you to just speak, and we will generate the medical records from it. And we won that bid. We were one of only, I believe, 49 projects that were awarded that. And that's where we started building. And then, the researchers and the academics in the room will know that very often you do these projects and then they sit on a shelf somewhere and they never make it to product and deployment and scale. And this is one of the things that I really, really wanted to scale. And I wanted this to become something that even the most unskilled maternal health worker could use. And so I carried it for about 2 years. And then, when it got to a stage where it had to be sort of formally start to scale and productize, and we needed a larger team and it needed to function as a startup, I was very lucky to find a co-founder and somebody who's been a friend for 18 years and who was just getting out of the tech industry and who had worked for 18 years in the tech industry, and who was now looking to do more impactful work. And so he came on board as a co-founder because, I have to say that I'm an academic and a researcher, and those are the things that I love doing and I love sort of understanding. I don't necessarily have the skill sets to manage very large teams and to think about scale and marketing and deployment in the ways that my co-founder does. And so I think that's one of the lovely things that has happened is that I now have a co-founder that complements that skill set. And that helps us sort of work on the startup and build it and scale it. I'm sorry, that got a little long, but does that answer your question?
It was great.
Yeah, that was super interesting. Dr. Mustafa, several folks wanted you to repeat the title of the second book, not the one Invisible Women, but the second one.
It's geek heresy. So I
Geek,
don't know if I
Geek Heresy. We'll put it in the chat and I'll repeat it at the end too. Geek Heresy. And we actually, the author is a friend of our program.
Kintaro.
Mm-hmm.
Got it. Okay.
Um,
Kintaro Toyomi. Geek Heresy. Okay. Thank you so much.
No,
Sorry,
we have
go
time
ahead.
for one more question.
Sure.
yeah, yeah.
Let me see. There were a couple of really interesting ones. So, another attendee is saying some AI proponents might suggest that their technology progresses and we will someday be able to use the technology to fill in the gaps in the underlying data and address some of the shortcomings that exist now. This attendee admits they are skeptical, but they're curious to hear your thoughts on this prediction. And as a global society, should we be gearing up for massive efforts to generate more foundational data needed for the next generation of AI?
Yeah, so, thank you for that, Todd. And I'm a bit of the more I do this work, sometimes the harder it is to stay optimistic that we will ever get to a point to where there are not isolated researchers and folks who are pushing for more inclusion and more equitable data. And so if I were to stop today, I don't know that there would be a replacement for trying to generate this kind of data for pregnant women in Pakistan, right? Whether that's language data. We have 70 languages. The only language that's represented is Urdu. So if I wanted to scale my product, I would need to first figure out how to generate the language data set. And so there are only so many data sets that I myself can generate. I know that there are efforts from the Gates Foundation to fund work to generate these language data sets, and I think that kind of goes a long way. I haven't talked about funding, but I think that's like such a key part of this work. Who are we funding and what are they doing? Are we funding sort of products that are building on biased existing data and sort of that's supporting this global north dominance, or are we funding folks that are really working? I know there's a lot of work happening in Africa. I think there's a lot more work and a lot more language representation, regional language representation in Africa than in Pakistan. And I think that's a function of how and what we've just funded globally, where funding has gone. But I don't think that we will ever reach a point because historically, when have we, look at how long the internet has been around and how long women activists have been talking about their representation in online spaces. And we have not reached a point where there is any kind of equity in that. So I honestly don't see that happening. I sometimes I feel it's a futile effort, but I think it is a worthwhile effort. And I just think more people need to be making those data sets and contributing to those data sets.
Absolutely. Thank you so much. Krista, would you like to close us out?
Yes, I'd be happy to. First of all, a giant thank you to Dr. Mustafa for today's session, and I think a lot for all of us to think about. Looking ahead, for those of you who'd like to join us for the next session of our seminar series in health innovation and equity, it is October 7th from 12 to 1 p.m. Pacific time, and we will have Jodrana Saunders, who's the founder and CEO of Trauma Recovery Services Arizona, and she will be speaking on restoring equitable mental health in Indigenous communities, and we hope we can join you for that. Thank you to my colleagues, Danny, Deja, and Antia for making today happen. And again, to Dr. Mustafa for being so generous with her time and expertise with all of us. For all of you joining us online today, we hope you enjoyed this session. And if you have missed or you're interested in other sessions of our series, please look online on YouTube for previous recordings. And for those of you who want to join us in person, particularly Stanford Community Bay Area, we welcome you at Stanford. So with that, thank you very much.
Thank you, everybody.
Absolutely. We also want to thank our partner,
Thank
Bay
you.
Global Health Alliance. And one question in the chat just came up. Yes, the session is recorded and we will soon share it on the YouTube channel. Thank you all for joining and have a lovely rest of your day, morning, evening, everywhere.